Welcome to the Skeptic's Guide to Emergency Medicine. Meet 'em, greet 'em, treat 'em, and street 'em. Today's date is December 23rd, 2025, and I'm your skeptical host, Ken Milne. The title of today's podcast is Dun 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 Dun. Under Pressure. To start antihypertensives in a hypertensive ED patient at discharge. And our guest skeptic is Dr. Mike Pallaci. He is a well-known professor of emergency medicine in Northeastern Ohio Medical University and a clinical professor of emergency medicine at Ohio University Heritage College of Osteopathic Medicine. He currently serves as core faculty for the USACS EM Residency at Summa Health Systems in Akron, Ohio, where he is also the medical director for the Virtual Care Simulation Lab. Welcome back to the SGEM, Mike.
Great to be back, Ken. I always love talking nerdy with you and going through some of these articles.
Well, thank you for taking a little time out before the holidays. We're going to squeeze this one in before everybody sort of shuts down and signs out to the emergency department, because you know that's happening tomorrow, Christmas Eve. The whole healthcare system, it seems, goes, you know what? Let's put the voicemail on, and it'll say, just go to Emerg. They'll take care of it. We'll be back January 4th.
Ken, how about you? What's the over-under for how many esophageal meat impactions you're going to see over the next few days? I got mine set at 2.5.
Oh, wow. Yeah, no. Because I'm up in Canada, we're talking about dog sled injuries, igloo collapses, all the usual tropes, falling in, ice fishing. I mean, if I'm going to be Canadian, I'm going to lean into it.
All right.
But you sent me an article, and what got you so motivated to say, I want Ken to do a critical appraisal of this paper?
Well, I've been talking and lecturing and podcasting and frankly obsessing about hypertensive non-emergencies for most of my career. And part of my mantra has always been that there's no guideline, there's no study, there's no evidence that treating hypertensive non-emergencies in the ED has any benefit. And there is some evidence for potential harm. I've also spoken out in agreement with these organizations who've said that the term hypertensive urgency should not be used because there's nothing urgent about a condition that in the only double-blind placebo-controlled RCT that's ever been done or ever will be done, that's the VA cooperative trial back from the around 1970, there was a 90-day adverse event rate of 0, whether the patients were sent home with treatment or with placebo.
Hey, Mike, that's my third favorite number, 0. It's a nice round number. As you know, my favorite number is 5. And in honor of Rob Reiner, my second favorite number is 11, because this one goes to 11. But I really do I like those round numbers. 0 adverse events, whether they got treated or not.
It's super easy to remember, right? 0. It's, no decimals, no fractions, nothing, just 0. So what this tells us, Ken, and what I've always preached is that it's long-term outcomes that are affected, not the short or even intermediate term outcomes. So when I heard about a study that found differently, that found that short-term adverse event rates could be decreased by prescribing antihypertensives from the ED on an outpatient basis, I was, it kind of piqued my interest. And once I dove into this a little bit and kind of got into the specifics of the study, I couldn't think of anyone in the EM space who'd be better to break it down with than you.
Well, thanks for sending it to me. I always like getting these things, and certainly if things challenge current practice or dogma. But let's be honest, you didn't just get a little interested. Didn't you go, Whiskey Tango Foxtrot? Really? Have I been teaching this wrong all this time? Come on, Mike, admit it. There was more than just...
to borrow a phrase, I was a little skeptical, Ken. So we dove into it, and we'll see what we found.
It's always good to question beliefs. There's a famous quote from time to time, it's healthy to go back and question what we thought was true. So that's good. So let's do that. And let's start with a case presentation.
Sure. So a 47-year-old male presents to the emergency department with an ankle sprain. Emitting vital signs include a blood pressure of 210/130, which is similar on repeat measurements. He has no complaints except for ankle pain. He's in good health, has no medical history that he knows of. And he has a primary care doctor who he hasn't seen in about 6 or 7 years.
So a very realistic case on a middle-aged male patient. Yeah. So when we look at hypertension, it's one of the most common incidental findings that we have in the emergency department. And in the US, there's close to 1 million annual ED visits with elevated blood pressure. And that number no pun intended, is climbing every year. Up to a third of these patients have no prior diagnosis of hypertension.
Right, Ken. And chronic uncontrolled blood pressure does have a strong association with a lot of long-term complications: myocardial infarction, stroke, kidney failure, heart failure, and increased death rates. So these incidental readings are not benign. Standard outpatient care focuses on confirming the diagnosis, usually with repeated measurements over time, and then assuming that this is truly essential hypertension, starting long-term therapy, lifestyle changes plus medications in order to reduce the rates of those complications that we talked about earlier.
Now, in the emergency department, we have a really awkward position because we're at the intersection between a potential chronic disease and acute care. And many patients that we see with elevated blood pressures, they have no symptoms. They're asymptomatic, or they have non-specific complaints with no clear sign of end organ damage. And the guidelines generally allow emergency department physicians considerable discretion, shall we say, about whether to initiate oral antihypertensive therapy at discharge versus just arranging follow-up.
Right, Ken. So the American College of Emergency Physicians, they've put out 3 different guidelines on how to manage these patients in the ED. The initial one was in 2006, then the follow-up was 2013, and then it was just updated this past year in 2025. And in that 2025 update, they gave a level C recommendation that said a few things. They said first that in patients with asymptomatic, markedly elevated blood pressure, routine ED medical intervention is not required. Nothing changed there. The second one said that in select populations, i.e. those with poor follow-up, emergency physicians may treat markedly elevated blood pressure in the ED and or initiate therapy for long-term control. That's a consensus recommendation. And the third one was that patients with asymptomatic, markedly elevated blood pressure should be referred for outpatient follow-up, another consensus recommendation, and that last one's not changed at all. The only change really of any substance was just some subtle changes in the wording of that second one about treating in the ED and initiating treatment as an outpatient.
And when we're talking about guidelines, Mike, I always like to remind people they are called guidelines, not godlines.
I love that line too.
And here we have a situation where they did, I think, a reasonable job because they gave it a level C recommendation. They recognize that we really don't have a lot of high quality evidence with patient-oriented outcomes of benefit to say, thou shalt start antihypertensives. And so they're allowing clinicians to be clinicians and talk to patients. We don't have really good evidence to say, you got to do this. And so you have to rely on your clinical judgment, but also engage with the patient about their values and preferences. So do they have follow-up? Do they have insurance? Do they want to go on an antihypertensives? All of these types of things come into it. And it's the art of medicine, not just the science of medicine.
I think one of the most important things that we do for these patients in the ED, Ken, is to have that conversation, right? To tell them that, to explain to them that it's really important that this is treated for the long term to decrease the rate of renal failure, kidney failure, heart attack, all those sorts of things. But that bringing it down now, today, is not only not helpful, but it's potentially dangerous because of medication side effects and other things like that, and dropping it too quick, overcoming the body's capacity for autoregulation. We don't have to explain it to the patient in that much detail. We need to understand that ourselves. But having that conversation and telling them the fact that it is critically important doesn't mean that it's emergent, and that bringing it down quickly and aggressively now could actually harm you without any potential to help you. It's the long-term treatment that really matters. That's really been the emphasis of my teaching, and I think the emphasis of what most people would teach for decades.
I like that, Mike. And one of the things that I add to it is you didn't get this way overnight. We don't need to fix it tonight. And so we can have a soft landing. And I also don't want to feed into there's a pill for every ill culture. And really, I'm wearing my primary care hat because I am board certified in primary care as well. And lifestyle modifications need to be emphasized before we reach into a pill bottle, because maybe there are other things that could be tried first before trying to find the solution in a pill bottle. So I really use that as an opportunity to recognize how important it is, like you said, over the long term. But there's a big but you can do things from lifestyle modification with regards to eating well, exercising regularly, just being physically active, those types of things that may bring down your blood pressure enough that you don't require to go on medication. And if we see a patient every single time and go, well, here's the pill, I think it gives a certain message that I'm trying to have a more holistic approach to treating the whole patient and using all tools and not just pharmaceuticals.
I think it's a great point, Ken. And, that's not always well received by patients. Sometimes it is, sometimes it's not. That down in my neck of the woods, south of the border, maybe a little less frequently than it is up in your neck of the woods. But I do think it's an important point to make, and it's something that we need to emphasize with patients for sure.
Well, and that's why in evidence-based medicine, we have that Venn diagram with those three circles and where they intersect. There is the evidence that doesn't tell us strongly one way or the other. We've got your clinical judgment, but then again, your patients might be different than my patients. And so it's about that individual patient's values and preferences, because they're the ones that are going to have to make those lifestyle changes, or they're the one that's going to have to take that pill every day. And so it's about them, not us.
For sure.
But to get back to some background material, previous work suggests that starting antihypertensives in the emergency department, it's safe and improves short-term blood pressure control in high-risk populations. Still, there's been little evidence, though, about patient-oriented short-term outcomes like heart attack, stroke, heart failure, and repeat ED visits. All right, Mike, what's the clinical question we're going to try to answer on today's podcast?
Among adult ED patients discharged with a diagnosis of hypertension and not on antihypertensive therapy, is an ED discharge prescription for an oral antihypertensive medication associated with a lower 30-day risk of severe hypertension-related adverse events, death, or ED revisits?
Oh, wow. It's all baked in there, right? Yeah, that's the question we want to know.
Mm-hmm.
So what's the reference that we're going to use to address this?
This was Dr. Todd et al. Out of Michigan. The title of the article is Antihypertensive Prescription is Associated with Improved 30-Day Outcomes for Discharged Hypertensive Emergency Department Patients. This was published in the Journal of the American College of Emergency Physicians, Open, in 2024, and actually got quite a bit of fanfare when it came out. Ken, got a lot of attention, at least down around my area.
Well, I didn't know that Dr. Todd was out of Michigan, and I don't know if you're going to be able to maintain some objectivity, because in the background I see a Buffalo Bills football team logo, and I don't know if you're going to be harder or more skeptical or less skeptical about Dr. Todd's publication because he's out of Michigan.
Not too much animosity between Buffalo fans and Michigan fans, Ken, but I do live in Columbus, Ohio, despite my Buffalo Bills loyalty, and plenty of animosity among my neighbors here in Columbus and anything from that state up north. So I will try to remain as objective as possible.
Please do. The Lions had a really good season last year. This year, not so much, but last year, wow, they had a really good season, didn't they?
They did, yeah. They took a tough loss the other night, but the hatred and the angst around my area isn't so much for the Lions as it is for the Wolverines. That Ohio State-Michigan rivalry is probably the most intense I've ever seen.
Yeah, I thought there was something in there. I'm not a big football fan, but I knew there was something about Ohio and Michigan. But let's get back to the PCOT. What was the population in this study?
All right, the population was adult patients, at least 18 years of age, who were seen and discharged from an emergency department within a single hospital system with either a primary or secondary ED discharge diagnosis of essential or primary hypertension or hypertensive urgency without prior treatment for hypertension during the previous 18 months.
And there were a number of exclusions. I'll list those in the show notes. What was the exposure in this observational study?
The exposure was receiving a prescription for an oral antihypertensive medication at ED discharge.
And who did they compare those patients to?
They compared the people that got a prescription with people who did not, discharged hypertensive ED patients who met the same inclusion and exclusion criteria, but did not get a prescription at discharge.
All right. And they had outcomes. What was the primary outcome?
The primary outcome was severe composite adverse events from hypertension within 30 days of ED discharge, which they described as an acute aortic catastrophe, acute heart failure, MI, hemorrhagic stroke, ischemic stroke, or hypertensive encephalopathy. That's the primary outcome.
And so that was a composite or composite outcome. What was the secondary outcome?
All-cause death within 30 days of ED discharge and ED revisit within 30 days of discharge.
And what type of study was this, Mike?
This is a retrospective observational cohort study.
So the author's conclusions were, quote, prescription antihypertensive therapy for discharged ED patients is associated with a 30-day decrease in severe adverse events and ED revisit rate. All right, let's go through the quality checklist for observational studies. Did the study address a clearly focused issue?
I think it did, Ken. Yeah, the population, exposure, comparison, time frame, patient-oriented outcomes, all clearly laid out in the abstract and goals. I think they did a good job with this.
And do you think Dr. Todd and colleagues used the appropriate method to answer their question?
Yeah, I think the methods that they use can determine whether there's an association, not necessarily causation, but an association, yes.
And do you think the cohort was recruited in an acceptable way?
I do. They used complete EMR census of all the eligible discharged hypertensive ED patients across the 8 hospitals within their system over the course of 4 years. They had very transparent inclusion-exclusion criteria. I think they did a good job with this as well.
And do you think the exposure, did they receive an antihypertensive? Do you think it was accurately measured to minimize bias?
This one I'm not so sure about. The discharge prescriptions were definitely well captured by the EMR, but antihypertensives written outside the health system would be technically misclassified as unexposed. There's really not any data on whether the prescriptions were filled or taken.
Yeah, it's an important point. We don't know if they actually filled their prescription. And on top of that, did they take it? And, there's pretty good evidence that not all the prescriptions we write are filled by patients. We think, oh, yeah, here's a prescription, and they run off to the pharmacy. That doesn't happen all the time. And just because they do fill it, and I'm someone who takes some prescription medicine, I forget to take it sometimes too. So we don't know if they're adherent to the prescription as well. How about the outcome, though? Was it accurately measured to minimize bias, that composite or composite outcome that they had for severe adverse events?
Not really sure on this one either. The outcomes were identified using ICD-10 codes in the same EMR and using regional death databases. This is pretty standard. It's the way that these studies are generally conducted, but we've talked about this a lot, Ken. I know you have on your podcast, and pretty much anyone that reviews the literature knows that this methodology, while there's not always a better way to go about it, there's lots of problems with this methodology and lots of potential to miss patients if they go to hospitals outside of this particular health system. There's lots of reports of database searches for deaths being incomplete. So there's definitely potential for some of these patients to be missed.
Yeah, and that's why it's important to know where the study was done. It was done in Michigan. If this study was done in Denmark, it'd be like, yeah, no, we captured everybody. It's hard to miss somebody. Or in other socialized healthcare systems where they have a really captive audience and there isn't alternative places to go, and it's all one single database. So it's really important to know that this study was done in Michigan. Have the authors identified all important confounding factors?
All of them? No. They did adjust for age, sex, race, what stage of hypertension the patient had, the ED treatment of hypertension. They use, I'm going to pronounce this incorrectly, I know, but I believe it's the Elix-Hauser Comorbidity Index, the ECI. How'd I do with that? Does that sound right?
Yeah, you did great. Yeah, no, it's much better than my Italian pronunciation of your last name.
We should just, I'll take the Italian pronunciations, you take everything else. And I think we'll be all right.
Sounds good.
All right. They also adjusted for prior heart failure. They used propensity weighting, but there was some things they couldn't really adjust for, at least plausible confounders, like medication adherence, socioeconomic status, access to primary care providers, and they did explicitly acknowledge some residual confounding.
And do you think the follow-up of the subjects in this retrospective study, this cohort that they had, do you think that the follow-up was complete enough?
Not really sure, Ken. I mean, all of these patients were followed for 30 days within the system with, I guess, censoring at the subsequent antihypertensive initiation, but visits and deaths outside the health system would be missed, not fully captured, especially if they were outside the region, but even with outside the health system. And the real proportion of the patients that were lost to follow-up is not reported, it's not known.
And how precise did you find their results?
I think they're pretty precise, particularly for the primary outcome. But for some of the rare components, for some of the rare diagnoses that we were studying, a lot more difficult to be precise when they're occurring so uncommonly.
Do you believe their results?
I believe it for association, but not for causation. And I think we need to be careful about what we're reading into it. This is a case of where we have to look at the difference between clinical significance and statistical significance. It's clearly statistically significant. The question is, how much of a true clinical benefit is there? And we're going to get into that a little bit later. The direction of the effect is certainly biologically plausible, and it's consistent with what we know of the long-term benefits of blood pressure control. But there's some residual confounding. The causal inference from observational treatment studies we have to be cautious in how we interpret that.
Absolutely. Now, you're in Ohio. So do you think these results can be applied from Michigan to Ohio?
I think so. For similar ED settings, yeah. It's a large, diverse cohort, both socioeconomically and racially, drawn from community, academic, emergency departments. Likely resembles most North American emergency departments, at least in reasonable proximity to a city. It's generalizable to different systems as well, I think. I think it's less generalizable to other systems like single payer countries like you up there in Canada, to rural only EDs, more remote settings, but to similar settings to where this was conducted. Sure. I think it's pretty generalizable.
And how does this study by Dr. Todd et al. Fit with other available evidence on the topic?
Well, other studies have shown that it's safe to prescribe antihypertensives at ED discharge, and it's been labeled as acceptable by the American College of Emergency Physicians previously, and that was reinforced with their most recent update. This is the first to show improved short-term outcomes after ED discharge. So while the safety is not a new idea and has been established before, the effectiveness of decreasing complications is, if we accept these results, this is the first study that would show that.
And where'd the money come from to fund this study?
They specifically and explicitly said that this was non-funded research.
So did the authors have any conflicts of interest?
They reported none.
All right, let's get into the results section then. After applying all their inclusion and all their exclusion criteria, they got over 90,000 ED visits with a discharge diagnosis of hypertension. And the mean age was 59 years. 57% were female. Just over half, 59%, were white. 10% received antihypertensive treatments in the ED. So while they were still there, they got something to bring down their blood pressure before discharge. And 1 in 20 received an antihypertensive prescription at discharge.
Right. So patients that were prescribed antihypertensives were younger. They were more often male, more often Black. They had higher blood pressure, both systolic and diastolic. They had fewer comorbidities. They were more likely to have received treatment in the ED, and they were less likely to have prior heart failure.
And what was the key result?
About 1 in 20 hypertensive ED patients got an antihypertensive prescription at discharge. Those who did had substantially lower adjusted odds of a severe 30-day adverse event and ED revisits, with no difference in 30-day mortality compared with those who did not receive a prescription.
All right, well, let's go through that with a little bit more detail. For that primary outcome, that was the composite outcome of severe adverse events within 30 days. What did they find?
0.7% complication rate in the untreated group versus 0.2% in the treated group. Adjusted odds ratio of 0.224. 95% confidence interval from 0.106 to 0.416. Number needed to treat was 183 with a 95% confidence interval of 161 to 247. That's to prevent one adverse event.
And let's go through their secondary outcomes. The first one was about all-cause death at 30 days. What did they find?
No statistically significant difference, Ken. There was 5 deaths in the treated group versus 105 in the untreated. But remember, 95% of the patients were untreated, so you'd expect the number to be larger. Adjusted odds ratio of 1.445 with a 95% confidence intervals that crossed well over the barrier of 1, 0.46 to 3.583. So the p-value is only 0.467. No statistically significant difference in deaths.
Yeah, and when they looked at ED revisits within 30 days, there were fewer in the treated group, 10% versus 16%, so an absolute difference of 6. And then they did an adjusted odds ratio. Again, that was statistically significant, and it provided a number needed to treat to prevent one bounce back or one revisit within 30 days of 18.
And in terms of individual adverse events, the antihypertensive therapy was associated with a statistically significant decrease in the odds ratio of heart failure, adjusted odds ratio of 0.183. No statistically significant difference in aortic catastrophes, in MIs, in ischemic or hemorrhagic strokes, no difference in hypertensive encephalopathy. With some of those components, there was zero of them out of the whole cohort.
You could have said my third favorite number, though. A nice round number.
0. Nice round number of 0. Yeah. I don't know if any of them had 11.
No. I'm rewatching This Is Spinal Tap over the holidays. All right, so let's talk nerdy. I love talking. You said you love talking nerdy, so let's see if you really do love talking nerdy, Mike. We're going to go through my favorite number, 5. So the first one is about residual confounding. This is an observational treatment study, so it's a retrospective one at that. It's not a prospective observational study. It's retrospective. It's not a randomized trial. And so the decision to prescribe is influenced by physician judgment and patient factors like their values and preferences. Now, when you look at it, the treated patients were younger, had less comorbidities, and were more likely to have received antihypertensives in the ED before they got discharged. And so this tells me that they were different systematically from untreated patients, even with this whole multivariable adjustment and inverse probability weighting, or what I like to call statistical jiu-jitsu. Unmeasured factors such as medication adherence, health literacy, or just the clinician's concern could both drive the decision to treat and influence the likelihood of a good outcome.
Yeah, definitely some potential for selection bias there, which we're going to talk about in a little bit. Another point that we're going to talk about here, number 2 of 5, is the composite endpoint. The composite endpoint of death, severe adverse event, or ED revisit. That's kind of like a composite endpoint of you die, you have an MI, or you sprain your ankle. So as you would expect, the vast majority of patients who met one of these criteria, which was 14,208 out of 14,978, almost 95% of them were repeat ED visits. There was no significant difference in deaths, which we already talked about. While there was a statistically significant difference in the severe adverse events, the number needed to treat to prevent one was 183. And the patients who did not receive a prescription had a severe adverse event rate of only 0.7%. I mean, that's a level of less than 1%, which is usually our target, right? So our starting point is a number that we're very happy with. If we want to make an intervention and we end up with an adverse event rate of 0.7%, we're pretty happy. So we're making an improvement in something that's already great with a number needed to treat of 183. They also didn't address the number needed to harm. from the side effects. And the treatments are generally pretty safe and the side effects are mild. But when you're looking at an adverse event rate of less than 1% and the number needed to treat is almost 200, now you've got to consider those mild side effects as well. There was no change in mortality. We've already said that a couple of times. And with an adverse event rate of 0.7%, to me, that should be the headline of the study. So it didn't really prove that we can prevent bad outcomes in a substantial way. It proved that we could reduce repeat ED visits with a number needed to treat of 18, but it proved that we can improve really, really good to a little bit better.
Yeah, I think that's a really important point when you're talking about how can we drive down something that's already 1%, like less than 1%. How can we drive that down further? And remember, this is a composite outcome, people. And I know you said, the composite outcome, the endpoint, do you die? Do you have an MI or do you sprain your ankle? I usually use the example of, death, MI, or paronychia. But I see what you're saying there. Like they're not all equal. And when you look at this, it was driven by return ED visits. And maybe that's a good thing. Maybe it's a good thing that they came back to the emergency department and had another visit because they didn't have a primary care physician. They needed another ED visit. We're not sure, but maybe another ED visit was actually a positive thing and not a bad thing that they came back. Very important point. All right, let's talk about statistical fragility. Despite this large cohort, they had over 90,000 people, the severe adverse event rate, less than 1%, right? With only 9 events in the treatment group. This leads to wide confidence intervals for some of the components, raising concerns about the statistical fragility. I mean, could we just go and blow this one over?
So what you're saying, Ken, is that the results are statistically fragile.
Fragile.
It is Christmas time, right? It's fragile. It must be Italian.
Well, the loss or gain of just a few events could meaningfully change the affected estimate. And this number needed to treat of almost 200 to prevent one adverse event, that sounds pretty precise and stuff like that, but it really rests on a very small absolute difference.
I don't think Ken really appreciated my A Christmas Story reference there. Hopefully some of the listeners got that one.
I'm not familiar with that Christmas Story because the best, and I will argue, and this is the hill I'm going to die on, Mike. The Christmas movie.
I know what you're going to say.
You know what I'm going to say because it's not Christmas until Hans Gruber falls off Nakatomi Tower. And tonight, yes, December 23rd, I am having an outdoor screening in Canada, people. Yes, in the snow. I'm going to be inflating my 16-foot movie screen theater event, have my outdoor projector, and we're going to sit out in the snow in the freezing weather and watch John McClane go to that Christmas party and deal with Hans Gruber. Oh yes, it will be epic.
I did not prepare for the Christmas movie versus non-Christmas movie debate regarding Die Hard.
Well, it's because there isn't.
I haven't watched it this December yet, so
there isn't one.
My 4 every December are It's a Wonderful Life, A Christmas Story, National Lampoon's Christmas Vacation, and Elf. Those are my 4 every December. Everything else is gravy.
Those are good ones, and I certainly do like Christmas Vacation. Oh,
so good.
Yep. All right, back to the nerdy section.
All right, number 4, selection bias, which I've referred to a couple of times. So including only patients that had one of 2 ICD-10 codes, either essential or primary hypertension or hypertensive urgency, including only patients that had one of those 2 as either the primary or secondary diagnosis, I think it introduces some pretty significant selection bias. How many patients had it but weren't given a diagnosis or had it listed further down the list because there were other diagnoses that the provider thought were more important or more relevant to the presentation? Those are probably patients where the treating provider was less concerned, and they might have had even lower event rates than the 0.7 or 0.2% that had adverse events in the follow-up period. In addition, the people that got treatment were healthier, younger, they were at lower risk, and may have, some would say probably have, had better outcomes because of that, as opposed to getting the prescription. So even with the deck stacked a little bit, the differences in significant outcomes were tiny. And that's with the selection bias kind of built into it.
And the fifth and final point, we've talked about this, about the exposure misclassification and the lack of adherence data or harms. The exposure is, did you get a prescription at discharge captured by an EMR order, which is appropriate for studies prescribing behavior, but it is only a proxy, a surrogate marker for the actual medication use. And the authors note that patients who received antihypertensives outside the health system would be misclassified as being untreated, and they had no data on prescription filling or medication adherence. There's also no data on the potential harms. And we've got to remember, when we're talking about a medical intervention, there are always potential benefits and potential harms. And you need both sides of the coin to determine where that's going to land. And so they didn't capture allergic reactions, angioedema, hypotension leading to falls, and other things. So it's really hard to know the net impact of an intervention if you don't collect the data on the potential harms.
Right. I think that they were banking on the previous data, Ken, that showed that these interventions were pretty safe. But again, when you've got a number needed to treat of almost 200, you really do have to measure that against a number needed to harm, especially when your baseline event rate is so low.
Yeah, and you've got the database. Do it.
Right.
Do it. But anyways, all right. So let's comment on the author's conclusions and then compare them to the SGEM's conclusions.
Right, so the major difference between the author's takes on these results and mine, and I think yours as well, you can speak for yourself, but the major difference really is how they're framed. Are they factually incorrect in how they present it? Not at all. They're technically correct and how they presented their findings, but how clinically meaningful is it? The take-home point for me is that baseline adverse event rate well under 1% at 0.7%. That's what our target usually is. That's the headline. That confirms our priors. That confirms what we already knew about this topic. So yes, in this cohort, there was a decrease in short-term adverse event rates, but it was from a level we were already very happy with to a level that we should be a little bit more happy with. Not from bad to good, but from really, really good to a little bit better.
Yeah, and it's important to remember that when they talk about the decrease in short-term adverse events, these are associations, not causation. So we've got all of these built-in biases, and at the end of the day, we're also talking only about associations. We don't have the information on harm. And so I don't think this is going to move my needle very much. But what's your bottom line?
For discharged ED patients with untreated hypertension, giving an oral antihypertensive prescription at discharge is associated with a reduced 30-day severe hypertensive events and ED revisits, but the observational design means we should be skeptical of the tiny potential benefit.
And hey, wait a minute. You had a case that the guy presented. He was 47 years old and he sprained his ankle. So what are you going to do with this guy who's got a sprained ankle, but he's got a blood pressure of over 200 over 100?
All right, Ken. So his ankle x-ray is negative. He's still asymptomatic, aside from the ankle pain. And he wants to know if we need to do anything about this elevated blood pressure that the nurses keep talking to him about.
So what are you going to do?
Well, I think this study reinforces the very low short-term risk of patients with elevated blood pressure without associated acute end organ damage in the ED. The adverse event rate at 30 days was 0.7% without treatment. The author suggests that this very low short-term risk can be further reduced by initiating antihypertensive therapy at discharge. This study shouldn't be read as a mandate to treat every elevated blood pressure, but rather as supportive evidence when you're on the fence about starting therapy at discharge. It appears to be safe and potentially beneficial, but the benefit is small.
So here's where you get to talk to the patient, sitting in the emergency department with that maybe tensor bandage around their ankle, and talk to them about their blood pressure.
This is an ideal place for shared decision-making, Ken. Shared decision-making and how it's evolved into how we talk about patients and make treatment decisions has been one of the most important developments in our specialty since I graduated residency 25 years ago. So you sit down and you share some information with them. You do it in layman's terms. You emphasize the importance of management of blood pressure for the long term, even in the absence of symptoms, to prevent those long-term complications like heart attack, stroke, kidney failure, and others. while you also stress that these are long-term risks and not short-term risks, and that the pressure needs to come down over the course of weeks to months, not hours to days. The likelihood of something bad happening in the next 30 days is significantly less than 1%, no matter what we do. We can start a prescription here, which is unlikely to cause significant problems and may make that even less likely. We can wait until you follow up with your primary care doctor and start it then, or I could call him or her to see if they have a preference. It's a low stakes decision. The likelihood of something bad happening either way is very low. What do you think?
I love sharing decisions with patients. It's really one of the favorite parts of my clinical interactions. I know some people like reducing joints and some people like doing other procedures and stuff, but sharing decisions with patients is really satisfying for me as a clinician.
And I do it across the board, Ken. I mean, this is a great situation for it. Influenza is the one where it's treatment of influenza is where I've really changed the most, because I used to be a hardcore no, I'm not prescribing Tamiflu. I'm just not going to do it. I don't believe the data. And what I've really evolved to is every one of those patients where we diagnose influenza, I do shared decision making and I share the data with them. If it's worth the risk of side effects to them for what may be just a shortened course of influenza, I'll prescribe it for them as long as they understand what the upside and the downside is. So I agree with you. It has really revolutionized my practice. I mean, we're just talking about 2 out of dozens of situations where I use this technique, and it's really improved my satisfaction with my practice in terms of making sure the patients are comfortable and they're happy and that they understand what the pros and cons of the interventions that we're looking at are.
It's like taking informed consent to the next level. That's what I think of it as. You're like elevating informed consent to shared decision making. And most things in medicine, we don't have thou shalt do this and thou shalt not do that. So most of it is shared decision making. And one of the things I use in the room, Mike, is I say I'm an expert at the literature. I mean, I'm an expert clinician. These are the things that I've trained to do, but I'm not an expert at you. You're an expert at you, and you have expertise on what you value and what you prefer and what journey you're on. And so we need to combine our expertise, and it really levels the interaction into a cooperative decision-making or shared decision-making process where their expertise and my expertise come together, and then we find a best way forward for that particular clinical encounter.
That's great scripting, Ken. I love that. I think I'm actually going to steal that. And, one of the things that I always make sure I relay to patients when I'm doing shared decision making is that, if there was a clear benefit to one over the other, I would be recommending that to you.
Yeah.
But I have this type of discussion with you when there's 2 or more reasonable approaches where they're both reasonable. I might prefer one. I might be on the fence between the 2, but if both are reasonable, I want to involve you in that decision. And that's going to be based on what your risk tolerance is, on a lot of different factors. So, I think developing this phraseology and developing this language comes with time and experience and just, going through it a bunch of times. I really love what you just said, and I'm going to incorporate that into my shared decision making in the future. But I think people who have done this a bunch, sharing it in venues like this, and giving our listeners some suggestions for how they can script this conversation or some phrases that they can incorporate into the conversation, I think is really useful.
Yeah, I find it enriching, and thank you for the kind words. I find it enriching, the clinical encounter, and it really respects the patient's agency and autonomy. It's their life. It's their risk. It's not mine. I am there as a consultant to offer my advice and my expertise, but they have to decide whether that fits with who they are. And I get that. And I want that same type of interaction when I'm on the other side of the gurney. I would like to have that respected and that I get to make choices, nothing to me without me.
Yeah, and you and I are both getting closer to that side of the interaction, aren't we? I think we're both north of that half-century mark now, aren't we, Ken?
North? Oh my goodness. I'm pushing 60. All right, it's time to announce the Keener Contest winner. And last week's winner was Dr. Casey Parker, a rural physician from Broome, Australia. He knew Andromeda was a princess of Ethiopia, Perseus's wife, and the daughter of Cepheus. She was apparently so beautiful that her father boasted she was more beautiful than the sea nymphs. Poseidon, he didn't like that at all. All right, Michael, what's the Keener contest question this episode?
Drum roll. Do the National Lampoon's Vacation thing. The Keener contest question this week is, who invented the sphygmomanometer?
And if you know the answer, you know the drill. All you have to do is send me over an email. And that email should be to thesgem@gmail.com. But you need to put Keener in the subject line so I can go through all my emails and find you quickly. And if you get the answer right and you're first, you will get a big shout out on the next episode. Well, thanks, Mike, for taking time again out of your holiday, or maybe you're ramping up to work. I don't know. But taking time out to do a show and talk nerdy with me on a really important topic that I think has really driven up the blood pressure of many ED clinicians.
Absolutely, Ken. Always good to talk with you. I look forward to doing it again sometime. Hope you enjoy the holidays as well. And happy holidays. Merry Christmas, happy Hanukkah, whatever holiday you're celebrating out there. Happy holidays to everybody out there.
And now you need to put on your thickest Italian accent to say the SGEM tagline.
Oh, man, I wasn't prepared for the Italian accent for this one. All right, let's see how I could do. Remember to be skeptical of anything you learn, even if you heard it on the Skeptic's Guide to Emergency Medicine.